Good afternoon. If I could have, have everyone's attention, we're very pleased to welcome you this afternoon to the 29th presentation of the LAVERNE GALLMAN Lectureship. I believe it's been. Today's presentation is bittersweet for us because Dr. GALLMAN is not here sitting in the front row, which every year I've had the honor and privilege to introduce this lecture since I've been dean and interim dean. And for the many years before when I attended as a student, she was always right here, nodding and enjoying meeting the lecturer, meeting the students. And of course, she is not here today. She passed away just this July at the age of 89. And we miss her. We miss what she meant to this school. She loved the lectureship. She loved attending it. She loved scholarship, and she especially loved students. So again, I just think of her every day. I miss her and her graciousness and kindness in our lives. Dr. GALLMAN led a life that was dedicated to nursing, in particular nursing education. And so most of you here are either students or faculty, and you have and will continue to benefit from her legacy. She first received her Associates of Arts degree from Kilgore College in 1943, and then she did what every one of you should plan to do, if you haven't already, which is she continued her education. Not easy. It was even more difficult in those days to do so, but she eventually got her bachelor's degree at the University of Texas Medical Branch, was integral in the beginning of the baccalaureate program at Mary Hardin Baylor. She commuted, which maybe it was easier then, but maybe it wasn't, from Temple, Texas to Austin to get her master's here, a Master's of Science in Education in 1957, and then later came to acquire her PhD in Education at the University of Texas at Austin. She continued her impressive career at UT Austin as a faculty member and in all kinds of roles of support to this school. She retired as Professor Emeritus, and before that she served as Interim Associate Dean for Academic Programs. And what we all remember her for, and I say we because I'm an alumnus of this program, was that she was Graduate Advisor for many, many years. And when she died this summer, I have to say I had tears, and I had many moments of reliving that as I heard from alumni all across the country, some who were friends of mine, some who I didn't know that well, and they would recount these stories that honestly I had sort of repressed in my mind about those anxious days of, oh my God, I can't get in that class and my world is over. And somehow LAVERNE always managed to make it okay, whether it was just explaining to us that we were going to live and there was another option and helping us see creatively, or she moved mountains to help nursing students get what they need. So she was a tremendous advocate for students, and this lectureship and the opportunities it has brought to this school, over 29 presentations to bring in distinguished lecturers, is really an opportunity for that work to live on. And while all our lectureships are special, and we have several here at the school, this one is very unique because it was not it wasn't established through the generosity of one single donor, which is typically what happens. Someone gives a large amount and we are very thrilled to receive it. But this one was actually started by the students and the graduates themselves. And Dr. Mary Lou Bond, back in 1984, I believe, collaborated with several other classmates, including, I was one of those graduate students at that time, and we started a drive to raise money, $25 at a time, $50 at a time, and through the graduate students and alumni and faculty, raised $26,500, which was then matched by the Regents and became the beginning of this lectureship that has grown over time. following Dr. Gallman's passing in July, we had a lot of, like I said, so many people contacted me and others, both at her services but also through electronic versions because our alumni are around the globe, and all wanted to find a way to express their appreciation for what she had meant in their lives. So I do want to let you know that the school is initiating a drive to fund a graduate fellowship in Dr. Gallman's honor. We have already have several gifts that are leading off in that, but Andrea Brannon, who's the one in the blue dress back in the corner, has forms, if any of you would like those, to contribute to furthering this effort in her honor. It will be dedicated to the support of graduate students, which we think is a very fitting tribute to the work that Dr. Gallman was so dedicated to. I would also be remiss if I didn't recognize Dr. Billy Brown, who's our former dean of the School of Nursing. If you would stand. And Dean Brown was the one who hired Dr. Gallman to come here, but I would also add that she hired me back in 1989. So I don't know if she considers that a good thing or a bad, but I'm thankful that she had that foresight to do so. Today, it's my pleasure now to introduce our guest lecturer that we have wanted to have here for over a year, and she's a very busy lady, so getting on her calendar with our calendar to mesh has taken some time, but I know it has been worth it. Dr. Kathy Dracup is our speaker today, and she holds a Bachelor of Science in Nursing from St. Xavier's University in Chicago, an MSN from the University of California, Los Angeles, and a doctorate in nursing science from the University of California, San Francisco. I could go on for the entire lecture period with her history, her background, and her achievements, but just a couple. This is like in church when they say they're going to be brief. You know they lie. No, I will be brief. She's a fellow in the American Academy of Nursing, and she's been inducted into the Institute of Medicine, where that was another one of our competing schedulers, as she serves on 2 committees for the IOM right now, so they keep her very busy going back and forth for those meetings. She's also held membership and leadership roles in the American Heart Association, the American Association of Critical Care Nurses, the American College of Cardiology, and the Heart Failure Society of America. I gotta get to my page here. She served as dean at the University of California, San Francisco School of Nursing, one of the top schools of nursing in the country, from 2001 through 2010. And after that, she returned to her role as professor in the area of physiological nursing. Her research career, which I'm sure she'll tell us a little bit about how that informs her talk today, has focused on studies related to care of patients with chronic cardiac disease and the effects of these diseases on the family. She's tested numerous specific interventions that were derived from the social support literature and and education and counseling programs to increase self-care among persons living with heart failure. Today, she's going to be speaking to us about the role of communication in clinical practice, and please join me in welcoming our distinguished guest, Dr. Kathy Dracup.
Sorry, just while I get mic'd up, and you'll tell me if, so is the mic in an okay place? Okay, great, thank you. And let me just continue getting mic'd up here. All right. Well, it is such an honor, and I want to start by introducing my granddaughter, Amelia Dracup, who is in her 2nd year of college in Texas. She traveled from California, where she grew up, because she loves Texas, and now I think she's going to immigrate forever. But it's been really fun, too, to have another reason to come and visit Texas. And so thank you so much. And Billy, it's just such a pleasure to share a room with another Emeritus Dean. You know, we survived to tell the tale. So today, we're going to focus on communication, and I think what I've learned since I've come is that you are now in the throes of planning for a School of Medicine, which gives you such an opportunity to really shape healthcare in Austin and in Texas for the future, because much of our work now is building interprofessional teams and looking at issues around communication, and we are battling culture and history that we all inherited when Dr. GALLMAN was working in the 40s and 50s on her degrees. So I think it's just really a wonderful opportunity to take a step back and sort of think about how communication works in clinical practice and how we can prepare physicians, nurses, pharmacists, social workers to be part of this team that is going to be really healthcare of the future. So first of all, I just want to say how fun it is to be in Austin, which has hills like San Francisco. We like to put cable car tracks on our hills and make for death-defying rides. But it's, it was interesting when I started looking at the similarities between Austin and San Francisco. There really are a lot. We have very similar populations, favorite tourist destination for many people, many ethnic restaurants in both places, and a thriving music scene, I think, certainly in Austin, and San Francisco likes to think of itself as having a thriving music scene. Austin, politically liberal and a little island. I'm impressed. And of course, we know San Francisco is liberal. 80% voted for Obama. It has a world-class university, which many of you attend. We also believe we have a world-class university. I did find on Wikipedia that your unofficial slogan was to keep Austin weird. I had never heard that. I thought that was so funny. That's just the reality of it. And just as an aside, I had just moved to San Francisco, and we had a clinic, and well, we had about 4 clinics at the time, and we were trying to develop a database so that all the clinics would have the same demographic and clinical information so that we could use our clinic for research purposes. And so I charged a group of people that worked in the clinics to come up with a database that everybody could use that would then, of course, move into this universal database. And they met, they had 3 meetings, and I said, how are things going? And they said, well, we really are having trouble with just the demographics. We just can't decide on how many categories for gender. I said, they had gotten it down to 6. So there you are. Okay, so another thing by preface, by way of introduction of this talk, is to just remind ourselves that we are on the eve, and I understand just by CNN headlines that Boehner and President Obama have come to a negotiation. So I think the government is going to be, at least for a little while, back in business again. And this whole issue about defunding Obamacare, that this is, I don't think any of us really believe this is going to happen, that California is already well geared up and has the exchanges going and really is using this healthcare reform to solve the problem that we have in California of hundreds of thousands of uninsured. So we are going to see this whole new group of people coming into the healthcare arena that didn't have insurance. And it really changes this, it changes everything for us. It changes who's going to be providing the care. And so the need for communication across the disciplines, the need for rethinking how we care for people is really key. The other thing I wanted to say by way of preface is just that I feel really well suited for this topic because I started out in cardiology. And in cardiology, this was an abstract that was published in Circulation in 1961. And it was sort of interesting because the gentleman was a physician in Los Angeles, Dr. Wilborn, who had started a coronary care unit at a private community hospital, wrote an abstract. The abstract got rejected from American Heart. I then had the similar experiences. But in those days, they used to publish the rejected abstracts. Who knew? And so this is the sentence I wanted to read. The coronary care unit is under continuous supervision of a physician or a specially trained nurse capable of recognizing ventricular fibrillation and ventricular standstill. Medical diagnoses that until that time within scope of practice law were not allowed to be diagnosed by nurses. So this was the beginning of the CCU, ICU roles of nurses, where nurses were expected to understand pathophysiology, physiology, be able to identify, and then act on those diagnoses before a physician could come even into the unit. That was the whole rationale for CCUs. Here, this was the yellow book that most of us read in the 60s that Dr. Meltzer wrote, and he also provided courses to nurses to teach them arrhythmia interpretation. And again, this is a line from one of the books that, from his book, that coronary care unit was really nursing at its core. And so I lived through, I still remember in the late 60s and saying I wanted to go to ICU, CCU to work. And someone said, oh, you mean where there are junior doctors? The whole idea that nurses were not nurses in the ICU because they were diagnosing and treating. So I come from a background where the nurse practitioner role was really already understood. And again, at the 50-year anniversary, Dr. Fry published an article kind of reviewing the history of CCUs. And I thought this was a wonderful quote, that the advent and diffusion of the CCU transformed the care of patients, the careers of cardiologists, and the boundaries of nursing practice in less than a decade. So we have had these times, and some of us have lived through them, where people question scope of practice. People question roles and boundary definitions within those roles. And very often, scope of practice regulations and legal definitions followed the change. So again, I think as we face healthcare reform, we're really dealing with exactly the same thing. The other thing I wanted to mention is that in 1971, I got a job as a staff nurse working in a CCU at UCLA. And this was an article written by the psych liaison at the time and published in 1977. So between 72 or 71 and 77, Ken Shine, who has been at the University of Texas for many years now, was the director of the unit. And after he was there about a year, he said, I think I'd like to have interdisciplinary rounds. So Tuesday afternoons at 3 o'clock, we had interdisciplinary rounds. He invited all the medical students, interns, residents, fellows, all the nurses, of course the co-director, the nurse co-director, the social worker, the psych liaison, and the dietitian. And we all sat around in this conference room and went through each patient that was in the CCU. And I still have very vivid memories of him saying, well, to whoever the primary intern or resident was, why don't you tell us about the patient? And they would start as if they were on morning rounds. This is a 41-year-old post-MI patient, anterior MI, the usual stuff. And he would stop them and say, no, that's not what these rounds are about. So what's his social support? Is he married or not married? What are the plans for discharge? Are there any issues around medications? He really understood that it was an interdisciplinary team and that he needed the team to communicate with each other. And I just think, that was such a wonderful experience for me and affected the way I thought of nursing and medicine working together. And that has been my experience over the years. But here, Ken Shine, who was in charge of health affairs at UT, had that sort of vision 40 years ago and has been very respectful of nursing and nursing's place on the team. So now, thinking about here we are in 2013, and what is acute care? Well, multiple disciplines are involved, of course, but now what's really different is shifting members on the team between resident hour limitations and 12-hour shifts and just the changing rotation in a teaching institute. We have just a lot of changes on this team, and this team has to figure out its relationships and its communication styles within the culture that we've all inherited. High levels of technology. We just had a terrible death of a young man with pulmonary hypertension because the nurse turned the stopcock the wrong way, and he got a huge injection of Flolan. So, these are things that we all live with every day, that we know we are giving drugs that can kill. if given inappropriately, or we are running LVADs or other technology that are, if not nursed competently, can kill. So the high level of technology and the fear attached to the consequences can really lead to errors, and those errors can be fatal, of course. The other issue that we have besides acute care and the changes in technology and the kind of care we can deliver is the change in our population. And I know no one needs to see any of these graphs because we are all living longer, luckily. And the average age for a male in the US today is average life expectancy is 78, and for a female, 81. But half the population that is born this year is going to live to over 100. And I know that this is, we're all dealing with this as we think about Social Security and Medicare, but it also changes the demands in the healthcare system in terms of the number of people that are going to come with chronic illnesses. So chronic care now, of course, needs to be community-based. Patient-centered medical homes are the way we're thinking about having to reorganize care. It always will involve multiple disciplines. Electronic charts for communication across the systems of care. It just is amazing to me that a man who's visiting California from Kansas can walk into a VA clinic and his entire medical record is there. And I know that's the vision for the future. I work in a system where if I get an annual mammogram, I never get a reminder, because if I get the mammogram in the women's breast clinic, which is on one street, or I get it in the Women's Health Center, which is half a block away, those two IT systems don't work together. So consequently, they can't send out a reminder because they don't know if I've had a mammogram lately. So how crazy is that? So figuring out electronic charts and HIPAA around the issues. The fact that most of our patients will have more than 3 chronic illnesses and deal with the polypharmacy related to that. And all of those can lead to problems in communication, problems in air. So this environment today, we know, is really focused on multidisciplinary care in a disease management model where we have discovered in research, particularly in the major categories of cardiovascular disease and diabetes, that those models will reduce mortality and reduce hospitalization rates. So we know what the model is. And in both acute and chronic health care, there's mounting evidence that interprofessional practice models will improve those patient outcomes, mortality, hospitalizations, complications, improve patient and provider satisfaction, reduce burnout, and decrease healthcare costs. So there's lots of research to say this is where we should be moving. We should be focusing on interprofessional practice models. So that's what I'd really like to talk to you today and ask if you think here you have the cultures and the strategies in place to incorporate a new medical school, a new member of the interdisciplinary team at UT, and a curriculum to support where people need to grow to. So we're going to talk about why it's important to talk about communication from a clinical perspective, from patient safety, what the barriers are, and you can probably think of a lot more than I can, strategies to improve both in clinical practice and in curriculums, communication across the disciplines, and discuss the current trends in health science education that supports interprofessional practice in the clinical world. So what do you think in this list would be the most important cause? Let me just ask, how many for A? Inadequate patient assessment. It's a problem. We've all can think of, okay. Unsafe physical environment. Can be, but probably not. Anesthesia. Doesn't affect everyone. Poor communication among, yeah, of course. So that's why I think it's so important that we focus on it as we think about how to keep our patients safe. So this is data from just 1995 to 2004, but it was the first time that we saw it, so starkly, that in terms of just sentinel events, when root cause analysis was done, that communication was absolutely number one by far. Orientation of staff, poor patient assessment, staffing issues, which we often think are to blame, but actually are pretty low down the list here if you look at the numbers, less than 10%. And then all the other things that we worry about, absolutely, but communication was number one. Medication errors, we know, are a huge issue, very great source of fear for patients and families. So it turns out that almost 2% of all Medicare patients have had an adverse drug reaction. 50% of those are preventable. I was looking for just medication error incidents and couldn't find it overall, but in a cardiovascular population of every 100 patients, there are 24 medication errors. So a quarter of patients experience some degree of medication error, not necessarily fatal, but. So looking at medication errors, what's the most important thing? Again, it's communication. And I heard a great example today of in talking with faculty, of a communication error that followed, from the order to the pharmacy, back to the nurse, yes. And when it was implemented was an error that, had serious consequences. So I think, we can all remember as a nurse having these experiences, but I think it's just really important to realize that it's almost always communication. And then wrong site surgery, I'm going to use poor UCSF because I serve on an executive board which allows me to hear about a lot of the problems that they have in care. But it is an excellent hospital, and I would go there as a patient, even though I'm going to tell you some horrific things. So we had a wrong eye surgery recently. Can you imagine? Yeah. And again, because the surgeon said, no, I'm not going to do the stick back, all the things that we put into place in the operating room to avoid errors. And again, communication is, at least in this database, the number one cause of error. Then in looking at the data from 2004 to 2011, the three sentinel causes were communication, leadership, and human factors. And in leadership, it really is the leadership identifying safety as being a big issue. So for instance, at Hopkins, which is often held up as being kind of on the, the cutting edge of looking at patient safety issues, because they had a horrible death there, a patient death. The leadership of the hospital went on rounds, walking rounds in the hospital, and the CEO of the hospital would say, what in your practice today, the patients you're caring for, what is a likely error? What might happen? And how are you working against that? How are you protecting the patient? So the CEO of the hospital was talking to a medical assistant or a staff, the clinical staff nurse or the intern, and saying, this is really important, and what are you doing today to make sure it doesn't happen? Fall out of bed, or whatever the fear was on the case. So leadership's message, I think, is really key. And then human factors around, like alarm fatigue. We're really discovering that in ICUs, alarm fatigue is a huge issue. Alarms are ignored because they're often wrong. So trying to figure out how to cope with that, noise, all of the human issues. And we have taken, of course, as we've started really focusing on communication and safety, we've really taken our cues from the aviation industry. So have you, for instance, at Seton, have you gotten the retired United pilots who are consulting all over the US and hospitals? Yeah. Yeah, and aren't they just so piloty? Yeah, they are. They're just, they really look like pilots and they act like pilots. But they've talked a lot about how the change in culture in the last 3 decades in aviation. How it used to be, you know, the pilot was in charge, broached no questions, and how as they were analyzing the black box, that was so clearly the reason often that there were terrible tragedies in airlines, and there's some, you know, some great examples of that. Interestingly now, we really see the same thing happening in operating rooms, you know, with the surgeons, that same culture of I'm in charge, don't question it. And that's exactly what happened with the wrong eye surgery. So I think looking at how aviation has changed its data in terms of the few crashes that have occurred since they've moved to this teamwork model. And most of the airlines bring their pilots in for a 3-day training every year. A friend of mine who flew always called it the touchy-feely 3 days. But, you know, because he thought it was sort of silly. But I think it was, in his case, it was because he communicated this way. He lived with a nurse. He communicated, you know, the way he was being taught in these touchy-feely. But at the end of the day, it's really recognizing the importance of every member on the team. And I'll just give you an example, again, from UCSF. So in the ICU, a nurse had been away on vacation for a couple of weeks, and she came back, got report. She went in to check on her patient, and the patient had stopped breathing. So she called an arrest, and the team, it happened to be during morning rounds, and one of the surgery teams was in the medical ICU just doing rounds. So the group came, you know, everybody comes in, and this very young surgeon wearing Ugg boots and looking, you know, very like he just stepped out of his Ferrari, comes over, and he's looking at the chart. And you know, it's the whole team, you know, when they've got the crash card open and they're doing it, and he's looking at it and he says, "Wait a minute, this is a DNR patient. We shouldn't be doing this." So they closed it all up, turned it down, and then afterwards, the nurse was in the cubicle by herself, starting to, you know, do the things you do when you're preparing somebody for the morgue. And she looked and realized that it was a chart that had been brought in by the surgical team. And her patient didn't have DNR orders. And so afterwards, when they were doing the root cause analysis, what she said was, well, I knew that I hadn't heard it at rounds or at report that he was DNR, but I just thought, oh well, it's just, you know, one of those miscommunications. She just accepted it. And because it was said so definitively, you know, this is a patient that's do not resuscitate, you know, by this man who, you know, was like totally disgusted that she didn't know that. She just accepted the wrong position. So it just, again, that example just reflects, I think, the kinds of problems that we often have in clinical practice, that we have to think about, you know, who's the lead? It should be the nurse in that. She's the one that knows the most about the patient in that particular setting. So thinking about what are standards of effective communication. They need to be complete, where you communicate all relevant information, clear, brief, and that's where nurses have often fallen apart, and that's why we've moved to models of communication and, you know, teaching our undergraduates and hospitals, working in hospitals, because at the end of the day, we want to very briefly give the context, give what we see as the problem or the diagnosis, make a recommendation, and do it in a way that saves face for everyone, you know, is respectful. So, and of course, timely, very important. A therapist said to me once in a marriage counseling session, you can be really mad at your husband if you've told him that you want him to do this. If you just wish that he would do it and think he should do it because he loves you, then that's your problem. And I think we often bring that kind of wishful, magical thinking to our interactions, you know, in the team, whether it's with other nurses or with physicians or other members of the team, where we think we should just be, you know, understood intuitively. And so I think it's really important to recognize that real communication has all these qualities, that we're just that clear. So what are some barriers then of, what is that kind of the classic communication loop in terms of, sending the message, making sure that the listener receives it. We were talking today about patient behavior and how difficult it is to change, but that as we communicate with patients, that's what the whole teach back strategy is that a lot of people have developed, and motivational interviewing techniques where you engage the person that you're communicating with, so you make sure that they're really listening, and then you clarify that they understand, that they can give it back to you again. So what are some barriers? Well, definitely lack of time. And that's why I think we all think about short staffing or issues around that we're overwhelmingly busy most of the time especially in acute care setting. But even, in chronic care, I've worked in clinics, and you're seeing a lot of patients in series succession, and it's really easy to forget or to confuse things. High workloads, cultural differences. Again, I'm sure everyone in this room has probably read When the Spirit Catches You and You Fall Down. But if you haven't, I highly recommend it. It is a really wonderful book about extraordinarily motivated family practitioners working in Fresno who really meant the very best, and in treating among family where the child had epilepsy and seizures. The problem of communication across that cultural divide between illiterate Hmong parents and the family practitioners is just an extraordinary example of the challenges that we have when we don't have congruence between the healthcare provider and the patient and family member. One of the things at the very end of the book that she writes about how in the Hmong family who came having fought for the United States in Laos, expecting to be cared for now, that was the sort of understanding that we will fight for you if you take care of us if we have to leave our country. And so they all, set up lives in Central California, and they had a whole different hierarchy. So of course the man was the aged man was the most important person, and the young female granddaughter was the least important person. But in the United States, because the young female granddaughter was going to school and spoke perfect English, she then became the most important person in that society. That's the person that all the doctors talked to. And so it was exactly the opposite. And so understanding that, I think, and understanding the hazards that puts up in terms of communication is really key. Yes?
Repeat the name of the book.
When the Spirit Catches You, You Fall Down.
Thank you.
And who is the author? Does anybody remember? Anne?
F-A-D-I-M-A-N.
That's right, Fadiman, F-A-D-I-M-A-N. Thank you so much. It actually was chosen by the University of California, Davis, as they choose one book club book for the entire university. And it was presidents, what can you say? And so that was their book, which I think was an excellent choice given where they are in California. Histories of conflict. So, again, if you've had a conflict, let's say you've had a conflict with a particular person on the team, a nurse, a physician, a social worker, and then you come again, your communication is going to be influenced by your past experience and how well you communicate and how much trust you have. And then, of course, all the other things that come with, working with other humans, our defensiveness, distractions. We know about all of, for instance, the Kaiser. When the nurses pass medications, they wear something that looks like an American Beauty slash, so that people know that they are preparing and passing medications and they cannot be spoken to. because they did a study that showed that, the average person was interrupted something like 8 times when they were preparing medications. Some hospitals have built sort of a place where you cannot cross, and if a nurse stands inside that and is preparing medications, you cannot interrupt him or her. Fatigue, which we know, interestingly, has fueled all of the 80-hour rules for residencies, but actually, I think, influences these 12-hour shifts. If you've worked 3 12-hour shifts in a row, you are not as sparky on that 3rd day as you were on your first day, let's be real. And nurses that have more than one job, I mean, that's another problem, I think, that no one anticipated with 12-hour shifts. That now, oh gosh, you have 4 days free. You can work another place. And hierarchy. And I just want to talk a little bit about hierarchy because it's what I so appreciated in working with Dr. Shine in those early 70s, where he came from Mass General. It is the pantheon of hierarchy. And this is a picture taken in the early 70s. You notice the pantsuit with the flared bell bottoms. And you notice the cap stripe? So do you remember if you were a student nurse, you wore a cap, there was cap day, and then you wore a cap, and when you graduated, you got 1 stripe. And then when you were promoted, we always laugh, I always say I stepped up from being dean, not down, but when you were promoted to nurse manager, you got 2 stripes. Well, that is just one of many, many examples of our history of hierarchy from the military. An officer of the day, so we have a chief nursing officer, a chief medical officer. How odd is that? But we have a lot of remnants of the fact that hospitals really found their beginnings in the United States after this and during the Civil War. That before that, people were cared for at home, unless you were very poor. And so now we have essentially the military hierarchy, and that has been legalized, that has gone into law, so that's shaped scope of practice. And it's just something to be really aware of as you're thinking about how we talk across teams. So this is what I think everybody is aiming for now, patient-centered care. I just was at the University of Michigan last week, and they have changed in their hospital the whole morning teaching rounds. So now there are no rounds conducted outside the hospital bed. So they all go in, they introduce themselves, they encourage family members to be there. The nurse is there, of course. This is particularly, there's so many acute care beds now. So the nurse is there or told, asked if he or she would come and participate. And everything is done in front of the patient so that all the communication is with the patient and family member. And there's none of the kind of the secret, okay, so now we're going to talk about the patient. Now we're going to go in and see the patient for a minute, see if there's anything, ask the nurse, is there anything you want to say, and then leave. It's really the team coming together. And I work at a place that started clinical pharmacy as a specialty, and every team has a clinical pharmacist on it, goes on rounds. It's a very different model. But a culture of hierarchy really speaks against it. And I think it's just really important to realize that that's our inheritance. So this is just a cartoon that I love. And I can tell you that in that family, this has been my experience in talking with physicians who are often feeling like everything is going really well. Things are good. My unit doesn't have any of those problems. And yet when you ask the rest of the staff, not just nurses, but any of the staff, oh no, lots of problems. And it really is that the person who has the powerful position in a hierarchy is the last person to know. And so, just as the marriage counselor hears, I have heard from many people, this is a horrible medical director. He's really whatever, distracted, never shows up, doesn't model well for the next, the students coming in. So I think it's really important to realize that we've inherited this culture from long ago, and that also we have philosophical differences. In the medical model, there's a real biologic focus, looking at disease, very much focused on getting, and for any nurse practitioners in the audience, it was very helpful for me to go through a nurse practitioner program and to realize how that frame of differential diagnosis, getting the right diagnosis, getting then the appropriate treatment plan, figuring that all out was paramount in this model, where in a nursing model, much more holistic, looking at symptoms and how those symptoms are managed, and what the socioeconomic determinants of illness are, cultural issues, the approach to treatment includes the social and behavioral environment, a very different focus. Both are very important, both are necessary as we care for our patients, but it does provide a somewhat difficult communication pattern for people. So what are some strategies to get over? We've talked about barriers, and there are many, but there are some strategies. We talked a little bit about what happened at Hopkins, that leadership set the bar really high. They expect everyone to be responsible for safety, and they're putting themselves right there too. Role modeling, I talked a little bit about Ken Shine. So many of the nurses in this CCU, when he was the director, went back to grad school, and he never once asked anybody about it. But there was something about the way he respected nursing staff. You just knew he thought you were intelligent and you probably should go back to grad school. And it was just, it just happened. And then the whole unit became a unit where that was supported, where they encouraged nurses to go to grad school and they'd figure out the schedule. Coaching, I think, is very important. We do some anger management sometimes, but also just general coaching of people who have communication problems. Exercises and shared decision making. There's been a lot of formal team training, Kaiser, Geisinger, a lot of the big systems who have recognized early on how important it is to create better communication patterns and better teams have either gotten the United pilots in or gotten foundations to give them money. And then, of course, doing the root analysis. When a mistake happens, looking, getting all the players, not just M&M conference where, all the physicians come in with closed door. So really looking at what the analysis of the process is. This is just a study that I looked at in terms of one particular clinical population. This was an outpatient oncology group. They had a 2-hour team training, 115 people went through it. There were surveys, both the patients and the providers, both of which significantly increased. And the reported errors, which is the bars that you see here, decreased. So pre-training, these were the number of errors. Obviously, this is really small. So there's not a lot of good data about how effective team training is, but essentially it's the best we've got right now in terms of changing the clinical environment. Other strategies that, this is another book I'd recommend if you haven't seen it, Atul Gawande's Checklist Manifesto, another short paperback. Great description. And one of the chapters is not about healthcare. He's a surgeon, but it's not about healthcare. It's about the construction industry and how when you're building a big skyscraper, you've got to figure out not just what comes first, plumbing, electrical, you have to put it all in order, but you also have to communicate. So they have a checklist of communication so that which is just as long as the list of construction issues. So he has a wonderful example. He did a project for WHO around the world about whether or not a checklist before surgery would reduce error. and found it did, published it. So these are from his book. Having a timeout or a brief huddle, which the ophthalmologist refused to do when he was going to do surgery. He said, we don't need it. I know this patient. Debriefing session afterwards, what went right. You know, the Blue Angels, after every flight, do a debriefing. What went right? Not just what went wrong. What went right? What went wrong? Checklists, which I think we've all adopted. Feedback among the team members, advocacy and assertion. You know, again, the example of the nurse who was the primary nurse for that patient, but doubted herself, doubted that she knew the information about her patient. Collaboration, call-outs, checkbacks, all of these are things that have been used particularly in surgical teams in the OR, but I think are just really important in any kind of acute care setting. Okay, and I just want to, in our last couple minutes together, talk about some of the cross-discipline efforts that people are trying to make as they look at the dilemmas that we have once we hit the clinical. So let me just ask, how many had some experience with other disciplines? Okay, about a third. How many? There's data to show that the majority of nursing students graduate having never spoken verbally to a physician. And if you think about it, if you don't have medical students on your campus or in your clinical sites, and you're with a preceptor, and you tell the preceptor, my patient today needs such and such, often the preceptor, thinking she is going to be helpful, says, I'll talk to the physician, or I'll call the physician. So if you can imagine, anyway, okay. So there have been a number of groups that have gotten together to talk about one of the first was IOM, who published this health professions education, and all of these are on their website. It's a book talking about how important it is that education of health professionals be done in a way that enhances communication, that they're interprofessional teams, recognizing that. And this is just from it. Although many successful examples of interprofessional education exist, interdisciplinary education has yet to become the norm. And that is the case. Where I am at UCSF, where there are only 4 schools on campus, because it's a health sciences campus, medicine, nursing, dentistry, pharmacy, it is at least traditionally, has been a very siloed experience. People could become a physician, an MD at that campus, and never talk to a nursing student. It's very possible, just because of the physical layout. So it's something that we really worked hard on the last 10 years and have tried to change, which I'll describe a little bit. I know a lot of you know about these core competencies, but it's one that really is driving all the curriculum discussion now. And again, it's on, the core competencies are available on any of these people's websites, but AACN, the nursing colleges, is an easy place to find. And that was done in May 11th. And these are the ones that everybody agreed on. First of all, that there should be competencies and values and ethics for interprofessional practice, that everyone should understand their own roles and responsibilities, but also the roles of others, that there be competence in interprofessional communication and competency in working on a team and teamwork. So I think all of these are really, now ones that haven't been emphasized in the past in curriculum. If you look at medical school curriculum, there was, this tremendous emphasis on physiology, pathophysiology, and basic science, and not on communication. The Macy Foundation, just in January of this year, had a conference, and the Macy Foundation, I think some of you have gone to their conferences. For the last 5 years, they've really pushed interprofessional education, and they also have grants that faculty can get to create interprofessional experiences or courses, which have been really helpful in creating, because it's money, and so it's been really helpful, for instance, in our place, to get faculty working together on interprofessional courses and interprofessional experiences. This is just a quote from the book. Historically, health professions, education, and healthcare practice have developed and functioned separately, with little recognition that the two are inextricably linked. And when I think about medical curriculum and nursing curriculum, all developed by educators, and nursing especially, because nursing, used to be so hospital-based. And then when it moved to the university, it really removed itself from that hospital control that used to use student nurses terribly. 6.5 days a week, and you must live here, and go to choir practice, and so nursing as a profession really wisely said hospitals are not going to dictate our curriculum. But the problem is they stopped talking to hospitals and other clinical sites. And so a lot of schools of nursing don't have input other than from their clinical faculty, who still are involved in clinical work, but don't have input by the people who are going to hire the graduates. And so it's something that we have to keep thinking about, as we change our curriculum. Are we developing the graduates for tomorrow, for this age of healthcare reform? What are the benefits? Well, it's just, it's so clear. In terms of improving teamwork, it promotes better understanding between professions, abolishes all these ingrained stereotypes, some of which are gender-based, improves healthcare outcomes, increases scientific knowledge. All of it is, for the good. So what are some strategies that schools of nursing and schools of medicine, schools of social work can use? Well, I was telling a small group today, when we started at UCSF, we only have 4 schools. All 4 were on different academic calendars. We couldn't even have a course together because none of us started at the same time. And so you have to look at, well, what are the structures, as you develop the School of Medicine here, and you want to have a lot of exchange with medical students and nursing students, you have to look at the structures that support or don't support it. Academic calendars. Some schools have a house calls program where teams of physicians, nurses, and pharmacists go out and do home visits, particularly in gerontology, which I think is just a great model for medical students and nursing students to learn each other's different agendas. A shadowing program where medical students shadow a nurse or a nursing student, and vice versa. Nursing students shadow someone in medicine, so that people understand the roles and how the day is different and what the demands are. So I think shadowing programs are easy to set up. I actually mentioned it we have an accelerated RN to MS program too at UCSF, and I mentioned it at the end of the first year of that RN pre-licensure program, and the students developed it themselves. They just got in touch with a medical school group through the student association and set it up themselves. It was not that hard to do, and it was really successful. Shared courses, of course, but just putting students from different disciplines in the same classroom is not interdisciplinary or interprofessional. But definitely clinic experiences, joint appointments. Nursing really wanted to distance itself from medicines being the teacher and nurses being the student. So consequently, they've really moved down on interdisciplinary faculty. But in reality, I think we all need, nursing faculty need to teach in medicine and vice versa, and across the other disciplines as well. Simulation labs are a great place to have teams of students work together and learn how to work together. These are just some examples that I know about. One, Medical University of South Carolina. This is a very small group, but nursing students, medical students, and PharmD students can apply to become a presidential scholar, and they get 2 years of funding that focus on a joint project. The Veterans Administration, and I don't know if Austin got a grant or not, but they put out a call for proposals, and San Francisco was one of the ones that answered it, where NP students and medical residents work together. And the idea, in listening to the person who's in charge of the VA, he said, there is going to be no lone practice of, physicians at the VA. It's got to be team now. As the VA population has increased in age, it's all chronic illness management. It's got to be teams. And they've got to figure out how to do this when they're training. Jefferson University in Philadelphia this was a really interesting story. I was talking to someone at the University of Pennsylvania about this. I just read about it. I'd never talked to anyone. And for every RN and medical student and PharmD student, they get assigned to a team of 3 to a family in the community. Now these families have to volunteer, and they go in and do a health assessment, like a public health assessment, and then they follow them for their 4 years of study. And one of the faculty said, so she's faculty on the University of Pennsylvania. She has a PhD in nursing. She's taught nursing for a long time. And she said, my oldest son goes to medical school at Jefferson. And he came home after his first visit to a family. He said, now I know what nurses do. And she said, well, I've been talking about this for, all your life. He said, no, but now I really understand how the orientation is so different because of how, the kinds of questions that the nursing student asked. So I thought it was sort of interesting. And then I know that you just got this wonderful $3 million to coordinate this grant. This is just, of course, off your website. And how important this will be in terms of helping you all to think about how to optimize multi-professional care, multi-professional preparation. I'm just going to tell you briefly about what we did. So starting in 2006, we started the first year with just 1 day of orientation where all of the first year medical, pharmacy, dentistry, and nursing students were all brought in, 900 students, into the gym, which was the only room that would hold that many students. And we did an orientation. All the deans spoke. We did a case study. We did an orientation to interprofessional care and talked about the different roles that people play on teams and how, whoever is the person most knowledgeable about the problem at the time is the leader, not necessarily anyone by virtue of their license or their orientation. And each year it has become more and more integrated into the curriculum. So now teams are formed on that first day, and each team has 8 people, 2 medical students, 2 nursing students, 2 pharmacy students, 2 dentistry students, and they meet all year with a faculty mentor. They do a project together. But in that, there is this opportunity to discover what each are learning while they're becoming, physicians or nurses or dentists, and also, what the difference in orientation is. And it's just been really successful. So just to summarize, I think a culture of patient safety requires both interprofessional education, and because we weren't doing it forever, it also requires team training. It's no use to have interprofessional education in a classroom and then send students out where there is hierarchy. And there are lots of constraints about communication. So we have to somehow change the culture out in clinical sites at the same time we're rethinking our curriculum. There are many traditions. We just had dinner last night with the new provost, who happens to be an engineer, Greg Fenves, and he was talking about how in engineering, everything is biomedical now. I mean, every field almost of engineering has some sort of biomedical And because of that, we see biologists and physicians and engineers and nurses all working together on devices or monitoring equipment or whatever it might be. And so I think, you know, all of the disciplines in science have discovered the importance of crossing these boundaries and having a variety of people in the room. And we really have to test some strategies and publish on them so that other people who are struggling can learn from us, learn from our mistakes as well as our successes. So at the end of the day, new attitudes and new technology and new communication, I think, lead to better clinical outcomes for patients. So thank you. So I'm happy to give these slides to anyone. If you just email me, let me know. Or I'd love questions or comments now. Yeah.
You know, when you were talking this morning about the 900 students in one room, what I was thinking was, why didn't you have a dance? Because when you know somebody socially,
Yeah.
the interactions are completely different. It's like playing golf. People that play golf together have 4 hours in the same golf cart, and you get to know somebody differently, and then you have a different level of respect for that person. And I think, gosh, 900 people, you got a gym, just need a van.
Although there would be no oxygen in that room, I'll tell you. People were like this, you know, they were, I mean, when I say 900 people, I mean, it was so crowded. But I think your point, I mean, that absolutely, it is true that people that socialize, they learn a lot about each other. But the problem is in clinical work often, you just don't have, because of the changing nature of the team, because teams are episodic, you don't have those opportunities to be working with the person that you celebrated their birthday last week. You know, when I was in the CCU, you know, a long time ago, we used to do liver rounds at the end of our shift, you know, go to a bar, of course. We were single, you know, everyone was single. We would all go do liver rounds so that the next day when there was, you know, some horrible experience, we had more than just our professional roles. We had our personal roles. And I found the same thing was true when I moved to a clinic setting as a nurse practitioner, where there was just a smaller group of us. There were about 10 of us. And we could celebrate birthdays and other things, absolutely. But I think it is more challenging in these acute care settings where you have a lot of, you know, changing membership.
How did you all go about getting your patient population, the ones where you had the group of students, followed them for 4 years?
Oh, that was at Jefferson. I think that they actually just put ads. Yeah, no, I think that they just put ads in, and I'm sure somebody had to interview them to make sure that this wasn't, you know, nuts. But yeah, but I think it's a great model, and they've done it for a while now. And apparently it's just been very successful. So, other comments, questions? Okay, I think there's a reception. Downstairs. Would you like a mic?
Thank you. Thank you so much for joining us.